Hi, good morning, everyone, and welcome to our Sickle Cell Data Collection Program for California's webinar series. My name is Miani Coker, and I'm tracking California's SCDC program specialist, and I'll be today's moderator. We have a great webinar planned for you today focused on end-of-life healthcare utilization for those with sickle cell disease and the potential need for the palliative care model. But first, a few housekeeping items. I have muted all conference lines to eliminate background noise, and the session is being recorded. The recording link and slide deck will be made available at casicklecell.org about a week after this session records. We will take written questions through the chat box or question function on your control panel at the end of this webinar. So without further ado, I'd like to introduce today's speakers, Emily Johnston and Oyebimpe Adesina. Dr. Emily Johnston is a pediatric hematology oncologist at the University of Alabama, Birmingham, who does end-of-life research. Her goal is to establish quality measures for end-of-life care for children, adolescents, and young adults, and then leverage those quality measures to reduce disparities in the end-of-life care. Oyebimpe Adesina is an assistant professor at the University of Washington in Seattle. She's also an adult hematologist who primarily takes care of adults with sickle cell disease. Her clinical research focuses on her early diagnosis and therapeutic interventions for skeletal complications of sickle cell disease with the goal of reducing their impact on development of chronic sickle cell disease pain. Emily and Bimpe?
Morning.
Good morning. Thank you so much for having us today. We're really excited to get to share our study and have a good conversation about kind of what people think the implications are. So we will talk today about a manuscript that we worked on with the Sickle Cell Data Collection Program called End-of-Life Healthcare Utilization and Sickle Cell Disease and the Palliative Care Model, and how patterns of end-of-life care for patients with sickle cell disease have implications for palliative care involvement with these patients. We'll talk a little bit about early mortality in sickle cell disease, which I think most of you are probably familiar with, and then move into exactly what is palliative care, so what we think could benefit these patients with some details of the manuscript, and then thinking through how and would people with sickle cell disease benefit from palliative care, and is palliative care available for people with sickle cell disease, looking at the University of Washington model for potentially integrating palliative care into care of people with sickle cell disease, and then some hypothesis-driven research questions that will help us figure out the best models, as well as policy implications for getting palliative care involved for people who could benefit. And then,
yeah, so, all right, good morning, everyone. This is Bimpe Adesina. So I'll start off our talk, our slide deck, and thanks again to my colleague and good friend, Dr. Johnston, for inviting me onto this project, and for the SCDC team for sharing their data with us. So this is a very sickle cell disease savvy audience, so I won't belabor the pathophysiology of sickle cell disease. I just wanted to stress that it does arise from a single point mutation on the beta globin gene. The downstream effect of that is red cell polymerization during periods of physiologic stress. Sickle cell disease runs the gamut from severe hemolysis to anemia, heterocellular adhesions, microvascular occlusion, hypoxia, reperfusion injury, and all of that manifests as recurrent painful episodes for our patients and downstream effects of end organ damage, which starts to accumulate in early adulthood. Next slide, please. There are myriad clinical complications of sickle cell disease. This slide does not fully describe everything, but it's a helpful slide to look at the common acute and chronic complications of sickle cell disease. And I like especially that it's broken down, sort of, you can see from top to bottom, every organ, every tissue in a person with sickle cell disease can be severely affected by their underlying disease. Next slide, please. However, the complications of sickle cell disease do accumulate with age. I really like this diagram, which is courtesy of one of my mentors, Dr. Hankins at St. Jude Children's Research Hospital in Memphis, Tennessee. going from infancy to adulthood, you can see that the list of complications grows and grows. And I highlighted death, which, you know, is a focus of what we're talking about today. But you can see initially in infancy and childhood, many of the complications are acute, and many children are able to get specialized sickle cell disease care in a clinical center that's dedicated to their care. And so they're there with their parents, and they have many, not most, but many children, and many children can get access to specialized care. However, in adolescence or young adulthood, a lot of that falls off. And so we start to see an accumulation in the disease side of things, an accumulation of complications. And then on the healthcare side of things, decreased access to care. And so that combination, in my opinion, is lethal, and is probably one of the reasons that we're seeing early death still, despite all the advancements that have been made in the management of sickle cell disease in childhood. We still see early death in young adults and middle-aged adults as well. Next slide, please. So this is a modified graph representation of mortality in people with sickle cell disease. So looking at data in the 70s to 80s, highlighted in the black graph, you can see that there was a bimodal distribution of mortality. So in the 70s and 80s, there was a peak mortality period before age 5, and then another peak right around age 20 or so. And so that was sort of how sickle cell disease was understood in about 40 years ago, where many children died in infancy or in very young childhood. And then those who did survive until adulthood, many of them died right around, the 20 to 24 age range, which is pretty tragic if you think about it. But with the advancement of many models of care, specifically around initiation of penicillin prophylaxis and malaria prophylaxis in malaria endemic areas, many children are surviving well into adulthood. Next slide, please. So if we move on to the red and green representations, you can see that mortality has significantly decreased in early childhood, but we really haven't made that much of a dent in early adulthood. Next slide, please.
Yeah, and
so I'll turn over to Dr. Johnston for this. Yeah.
And then we want to spend a little bit of time discussing what is palliative care, because even amongst healthcare professionals, we know that there are a lot of misconceptions about palliative care, with some providers still continuing to equate palliative care with end-of-life care, and others will even say that palliative care is essentially hospice care, which is clearly part of what palliative care offers, but there's a lot more to their services. So just kind of going through some of the common holistic views of palliative care. Palliative care is care that seeks to prevent, relieve, reduce, or soothe symptoms produced by serious medical conditions or their treatment, and to maintain a patient's quality of life. And so I think clearly with the data that we just heard about, sickle cell disease would definitely qualify as a serious medical condition. And then palliative care and the medical subspecialty of palliative medicine is specialized medical care for people living with serious illnesses, again, easily including patients with sickle cell disease. And it focuses on providing relief from symptoms and the stress of a serious illness, with the goal to improve quality of life for both patients and their families. And then overall palliative care is provided by a team of palliative care doctors, nurses, social workers, and others who work with a patient's other doctors to provide an extra layer of support for patients to address some of these issues. And it is now considered to be appropriate at any age and at any stage in a serious illness, and can be provided along with curative treatment. So what is, I think, striking to a lot of people about these definitions is that there is nothing about end-of-life care in them. Clearly, palliative care is essential for many patients at end of life, but that is not all that they have to offer. Next slide. And so who is providing palliative care? Who is providing these services to improve quality of life and symptom management? And the way we can think about it is providers providing primary palliative care, secondary palliative care, or tertiary palliative care. And primary palliative care can be provided by any clinician when they are talking about symptom management and goals of care and have the knowledge to do that. Secondary palliative care is provided by people who are trained in palliative care but are working out in the community. And then tertiary palliative care is more specialized palliative care that is happening at tertiary care centers by palliative care physicians. But as you can see, the vast majority of palliative care provided in this country is primary palliative care by, hematologists and pediatricians and general practitioners rather than people with specialized training in palliative care. Next slide, please. Kind of going back to that initial question of what is palliative care, connected to that is when should palliative care be involved? And there has been a lot of evolution over the years in those definitions of palliative care that we talked about, but also in when is the appropriate time to get palliative care. Kind of the traditional model is shown in the first block there, where you'll have a curative intent with treatment, then move into palliative mode where you're working on symptom management and have death and bereavement. That then moved into a model of trying to have concurrent cure-directed therapy and palliative care at the same time in order to, while working on cure, to also be working on quality of life and symptom management and all of those as you slowly transition into death and bereavement and kind of have a slow transition from cure-directed therapy to more palliative therapy. And the most recent models are more integrative, with really palliative care being integrated in throughout treatment, working on both curing and healing in a more holistic sense, including palliation. And so really an integrative model of palliative care throughout treatment is what is most common and is frequently most appropriate for patients with chronic illnesses like sickle cell disease. You can go to the next slide. So we're then going to move into the manuscript. You can go to the next slide. And given what we just talked about, sickle cell disease in terms of quality of life and symptom management, in addition to end-of-life care, I want you to think about the manuscript and the results we share through the lens of what do our study results say about palliative care for people with sickle cell disease. You can go to the next slide. And with the help of the Sickle Cell Data Collection Program and really a lot of efforts by Susan Polanka on us, we were able to publish this manuscript in Journal of Palliative Medicine last year. And you can go to the next slide, which addressed our two goals to identify where are people with sickle cell disease dying and what are their patterns of care in the year preceding death, for two reasons. One, to figure out where people with sickle cell disease are spending this final year. So if we want to target resources, both in terms of preventing death, but also resources in terms of ensuring that they have appropriate advanced care planning and things like that in place, we knew where we needed to go to access these patients. So we used the California Sickle Cell Data Collection Program data linkage of data from the Office of Statewide Health Planning and Development Administrative Data, which includes discharge records from every hospital in the state of California, except a few exceptions such as veterans hospitals and prison hospitals. And every hospital is required to report their discharge information, which includes a wealth of information, including age, race, ethnicity, and diagnoses during the hospitalization. That is also linked to vital records, so linked to death certificate information, and also linked to Medicaid claims for even more detailed information than is available with the administrative data. We, with that, as you will see, we identified people who died of sickle cell disease during our years and then matched those deceased cases to people with sickle cell disease who did not die as our controls. And we examined their claims, both using the Medicaid data and the administrative data to examine their claims in the year before death to see what their patterns of care were in that year. Next slide. So our data set ended up including 486 people who died with sickle cell disease. So we initially started with the California Sickle Cell Disease case data set, which has very strict criteria in terms of number of sickle cell claims and to ensure accurate capture of cases. We then identified patients in that data set who were linked to death certificate data. And we wanted patients and as much as possible who were dying from complications of sickle cell disease rather than people dying of other events like trauma or peripartum events. So we've removed people who died of trauma or other peripartum events. We had data for 2006 to 2015 in the full data set, and then after we verified date of births and things like that, and excluded patients older than 79 years old without confirmed cases, we ended up with our final sample size of 486 patients. Go to the next slide, please. And then the demographics of the people with sickle cell disease in our cohort, as well as their matched controls, you can see that as we talked about earlier, there's a lot of early mortality. You can click the next button, it'll pop up as a, that 30% of the patients were dying between 22 and 40. So really young adult, dying in the young adult age group. Next. And 62% were older with 41 to 79 years old. Next. And insurance at the last healthcare encounter was 83% public, which clearly, as I think most people know, there's a lot of policy implications when talking about changes in care for people with sickle cell disease because they are so covered by Medicaid and other public insurers. Next. This graph shows location of death of people with sickle cell disease by age, and you can see location along the x-axis and the percent of population along the y-axis with location of hospital, emergency department, home, and nursing home. And as you can see, the vast majority of people with sickle cell disease are dying in the hospital, with overall just under 63% of people with sickle cell disease dying in the hospital. The second most common location of death is the emergency room, with 15% of people with sickle cell disease in this cohort dying in the emergency room, with 14% dying at home, and then small percentages dying in the nursing home or other situations, and very few dying on hospice. Next. And then of those who died in the hospital, 57% of those hospital deaths occurred after admissions of less than 3 days. So people with sickle cell disease appear to be dying in the hospital and the emergency room, and doing so in a pretty acute manner rather than having prolonged hospitalizations that end up in death. Next slide. And then moving beyond just location of death, we also wanted to examine patterns of care in the preceding year by month, with looking at the cases, so that those people who had died versus the control, so those who were alive. And as you can see here, we've got 4 graphs with, along the x-axis, we have the months before death. So death is on the left-hand side. And then we have number of hospitals admissions per month, days admitted, ED visits, and percent of patients admitted to the ICU. So with the number of hospital admissions, you can see that throughout the year before death, those patients who died generally had more hospitalizations than the controls, with a very sharp increase as death was approaching. For the number of emergency room visits per month, there was much less variation between the deceased cases and the alive controls, with both having pretty steady emergency room department use throughout the year, pretty comparable emergency department use throughout the year, until again that last month before death, when those patients who died had a drastic increase in the number of emergency room visits. And then moving up to the upper right, the number of days admitted, the people who died had more days admitted than those who, the matched controls who were living, but that more steadily increased throughout the year rather than just that sharp increase at time of death. And then ICU admission showed a very similar pattern to emergency department visits, with both live cases and dead controls having very similar, dead cases and live controls having very similar rates of ICU admission throughout the year, with a sharp increase in that month before death. And next slide, please. And then this breaks, and I'm trying to better understand what the disparities might be in some of those patterns. Wanted to break things down both by insurance and by age. So on the left-hand side, you have private versus public insured patients, and then on the right-hand side, you have age. So looking at the insurance, we have number of hospital admissions per month by insurance, and you can see that both privately and publicly insured people with sickle cell disease had similar utilization patterns in the year before death. And the same thing was true for emergency department visits per month by insurance, where both private and publicly insured people with sickle cell disease had similar utilization in that year before death. By age, we have our more pediatric population, age 0 to 21, the adolescent young adult population of 22 to 40, and then the older adults of 41 to 79. And interestingly, you can see that in the upper right, the number of hospital admissions per month was comparable for all three age groups. However, when you look at the emergency department visits by month, you can see that those 22 to 40-year-olds that, as we were talking about, are a very vulnerable population with transitions from pediatric to adult care, had much more emergency department utilization than those patients who were either younger or older than them. The next slide. And then also kind of getting back to that issue of access, we wanted to see if people who are dying of sickle cell disease are being seen at specialty centers or not in the year before death. And so these graphs, again, have month before death and then have percent admission at specialty centers. And again, the graph on the left shows our dead cases versus our alive controls, which you can see had relatively comparable rates of specialty center admission, although as you can see, for both, only about 10% of admissions are happening at specialty centers, with a slight increase in specialty center admissions in the month before death. And then going by age with those three age groups again on the right, you can see that basically patients 22 to 79 had very similar rates of specialty center admission the year before death, but the younger patients were much more likely to be admitted at specialty centers than the older patients, which gets back to that access issue we were talking about at the beginning. Next slide. So I think some of the key take-home points for us from this article were that people with sickle cell disease are still dying at a young age, with so many of those deaths occurring in that 22 to 40-year-old age group, and that most die in the hospital or in the emergency room after brief hospitalizations. So there's not necessarily a lot of time to prepare and make decisions, but that these things happen pretty suddenly. Next slide. All right, and then you can turn it back over to Bimpe for the next set of slides.
Thank you, Emily. Next slide, please. So we asked ourselves the question, based on our findings in this paper, would a comprehensive palliative approach to people with sickle cell disease, it should extend beyond chronic pain management and psychological or psychosocial support. How would we use this to include advanced care planning? I think these are very important and very clinically relevant questions. Next slide, please. So looking at sickle cell disease, so I'm an adult hematologist, as mentioned earlier, so I want to just put that in focus because I do know that a lot of my pediatric colleagues practice in comprehensive sickle cell centers, which is the model of care, but there are different sickle cell models of care in the adult world that I just wanted to highlight for the audience, and I put some examples here, but there are many, many more. So the classic sickle cell disease comprehensive center, once again, it's what many of my pediatric colleagues practice in, and as a trainee, I had the opportunity to, work alongside them, knowing fully well that as an adult hematologist, I would have to modify my approach when I started running my own center. So just to give you all a background, it's a team-based approach, excellent team-based approach. You have dedicated clinical space and staff. There's usually an infusion and a day hospital. It is led by a sickle cell disease specialist, not always a hematologist, but a person, a physician usually with a sickle cell disease expertise. They do also have access, incredible access to many subspecialists, and it's truly a comprehensive approach. Like, once again, if you remember to my earlier slides, patients with sickle cell disease, people with sickle cell disease can have complications from the head to the toe with their sickle cell disease. And so a cardiologist, pulmonologist, nephrologists, radiologists even, there are many different subspecialties that interact with the sickle cell disease specialist or the sickle cell disease team in a comprehensive center. If you go on to the Embedded Adult Sickle Cell Disease Center, which is what we have at the University of Washington, once again, it's also a team-based approach, but you have to sort of partner with other disciplines in the cancer center, including palliative care. And so that's where that comes in for our service, for our team. It is a shared space. It's not dedicated to sickle cell disease in particular. We are sharing space usually with oncology or leukemia, lymphoma. We often have to share an infusion center or a day hospital. And it's sort of, I always think sometimes it feels kind of like you're the stepchild. You kind of get the scraps after everyone else. But you know what? It's better than nothing. And so I just have to constantly or sort of repeatedly ask for what I believe my patients deserve. And so it's just, showing that actually allotting space in the day hospital or the infusion center for our patients is cost effective to the cancer center. And so just making that argument repeatedly often gets us what we need. It is once again led by a sickle cell specialist. So me, in the example of the University of Washington, our model. But I have multiple team members that I work with, and some of them may even be on this call. So I work with mid-level, so advanced practice providers. We have a dedicated sickle cell social worker. We have a dedicated clinical nurse coordinator, a dedicated person who schedules our visits for us with our patients. And we have access to all the necessary subspecialists. And I often think about it as a phone a friend model. So, I try to refer my patients to, the same nephrologist or the same cardiologist or, as we're going to allude to, the same palliative care specialist, so that we have a rapport, we have a relationship, we have an understanding of what sickle cell complications can be in adults, and are able to partner with me in caring for my patients. Then the two other models here, I won't dwell too much upon, the specialized sickle cell disease medical home. Once again, it's also a team-based approach. You do have a dedicated clinical space and staff. It often includes a primary care specialist or a primary care person within the medical home, and there has to be a care coordinator, so a sickle cell care coordinator or a patient navigator. It doesn't always necessarily include an infusion center or day hospital, but they might have access to that. And it's where many individuals who have difficulty coordinating care, like coordinating the complex care that goes into some of our adults with sickle cell disease, this is where they get the help that they need in a medical home. And then the last model that I'll just briefly talk about is the hub and spokes model. So the hub is probably one of the, it's probably a comprehensive center or an adult center or an adult embedded center within a cancer care is the hub. If you think about it as like a bicycle hub with all the spokes sticking out. So you have a central hub, and then the spokes are usually run by primary care physicians or primary care providers within the community. They may or may not have an infusion center, and oftentimes there is sort of a telehealth or outreach approach to all the centers that sort of feed into the hub. And it's usually involves co-management of these patients, of people with sickle cell disease for it to be successful. Next slide, please. So thinking about the sickle cell disease palliative care model that we envisioned for the University of Washington, I want to definitely give credit where credit is due. It was our social worker who kind of came up with this idea because she bridges the gap between social work and sickle cell. And social work is closely affiliated with palliative care at our center. And so she thought, this is, as Dr. Johnston mentioned, this is a chronic disease. It's sort of the prototype of chronic diseases, if you think about it. And so why not figure out a way to partner with palliative care, since their expertise is managing symptoms of chronic disease, and sickle cell disease would be an ideal one. And so about a year ago, or a little over a year ago, May of last year, the program director for the palliative care palliative care program at our center, at our Cancer Care Alliance, she reached out to me after speaking with our social worker to figure out how palliative care could better serve our adults with sickle cell disease at our center. So just as a reminder, we are a program embedded within a cancer center. And so we had a multidisciplinary meeting that involved palliative care, our sickle cell team, chronic pain service, social work, chaplain, and the operations manager to come up with an approach where we could maybe not necessarily marry the two teams together, but have a very cordial relationship where we could co-manage patients. And we met about a year ago, and then in follow-up conversations, we had the idea of having palliative care fellows or their mid-level providers, advanced practice providers, rotate with our team in our hematology clinic. And then I also shared with them lectures that I had given to the house staff on management of sickle cell disease complications. Many of it, my talk to the fellows really focused on acute management, but I also talked about chronic complications of sickle cell disease in adults, and I shared that with a palliative care team. And then we had other follow-up conversations about having a more focused or interactive didactic that I would present to the palliative care team. We had planned to do that earlier this year, but in light of the pandemic, a lot of that got put on hold. And then what we really envisioned is co-managing many of the complications. Mostly what we focused on was chronic sickle cell disease pain, but we also wanted to figure out a way that we could manage other complications with our palliative care colleagues. Both of our teams kind of have a high no-show rate, so we were thinking about how do we reduce that no-show rate? How can we, like one team or one service would go in with a visit with the other. So for instance, if a palliative care fellow who was assigned to see a patient in clinic had a cancellation, he or she could then page me or my team on the day of our clinic and say, oh, my patient didn't show. Do you want me to come in and shadow with you or meet your patient with you? And that way sort of overall try to reduce the no-show rates in both of our clinics by having that approach where we meet where the patients are. So for me, my sickle cell, my adults with sickle cell will come at least once a month to see me, especially if they're on disease-modifying therapy. And so it would be a great sort of captive audience to have the palliative care fellow come join in on some of those visits if they had a no-show in their clinic. So that's what we envisioned. It hasn't, we haven't developed it fully yet, but these were some of the ideas that we came forward with this sort of marriage of sickle cell disease, or partnership, if you will, of sickle cell disease and the palliative care teams for our center. Next slide, please. So I believe, Dr. Johnston will chime in, but I also believe that thinking about how sickle cell disease or palliative care could be embedded or could be integrated into the different specialty centers, you first of all have to understand what model you actually have and what your access is to palliative care, and how to build a relationship with the palliative care providers at your institution or at your facility, and whether or not sickle cell providers felt comfortable approaching or comfortable taking over the basic palliative care skills with chronic disease management, and then when to reach out or phone a friend in palliative care for more advanced care or that tertiary care. And then also thinking about whether or not people would actually benefit. So people with sickle cell disease, would they actually benefit? It's been shown in the oncology literature that cohabitating or dual administration of potentially curative chemotherapy or curative chemotherapy or oncological care with palliative medicine actually led to improved quality of life and possibly increased overall survival. There was a very famous paper in 2010 looking at improved overall survival in patients with metastatic lung cancer as they were receiving lung cancer therapy, chemotherapy, and radiation and whatnot, in addition to palliative care. And so the question is, would that also apply for people with sickle cell disease? And then looking at what the potential qualitative research could be in people with sickle cell disease to see if palliative care is an option for the patients that we serve. It would be very important, as we're doing in this forum, to just ask what is the perception of palliative care? Because I will say, full-on disclosure, I also was in the camp that it had to do with end-of-life care, and I knew very little until I started working on this project with Dr. Johnston. I knew very little about all the other, the broader scope of palliative care and how it could apply for my patients, seeing if my patients are open to palliative care and what would be the best method to access palliative care, and also to assess whether my patients would be open to engaging with palliative care. So I think it's a very important thing about educating and definitely dispelling myths about palliative care only related to end-of-life management, and broadening the scope in my mind, in my team's mind, and sharing that information with our patients in close collaboration with our palliative care colleagues, I think is a way to begin this process of asking important questions. Next slide, please.
Oh, actually, can we spend a minute? Can we
Yes.
spend a minute on? Yeah, sorry.
Yes, we can go back.
Sorry. Yeah, and I think related to that, just talking about some of the, I think we have a lot of intuition and evidence that there would be palliative care would be beneficial for people with sickle cell disease. But one of the big issues that comes up with people with sickle cell disease again and again is access issues. And there is already a palliative care shortage in this country in general. So frequently when trying to reach out to palliative care teams to have them start seeing a new group of patients, there's quite a bit of pushback because of capacity, and both in terms of palliative care capacity at individual centers, and then whether or not centers actually have palliative care, because even as of a few years ago, 30% of cancer centers treating people with cancer did not have palliative care. So really needing to figure out whether or not people with sickle cell disease have access to palliative care, with palliative care even being available, whether or not palliative care is even available at the centers that people with sickle cell disease are getting treated at. And in terms of then allocating that precious resource that is palliative care, who are the people with sickle cell disease who would benefit the most? So who are the ones that would most benefit from that comprehensive approach to chronic disease management, or the ones who we think are at high risk of mortality and really do need to have advanced care planning and wills with guardianship clauses and all of that in place. And then with that, then can figure out how to best integrate specialty palliative care into the care of patients with sickle cell disease. And then when palliative care is done at sickle cell disease specialty centers, how to make sure that those sickle cell disease providers are comfortable. And then I think finally, as Bimpe talked about, the qualitative needs to really better understand people with sickle cell disease and their perceptions of palliative care and whether or not they're open to receive it. But just, I think talking about palliative care without addressing workforce shortages, both in terms of number of palliative care physicians and location of palliative care, is challenging.
Indeed, I couldn't agree more. I also think it's important to note that there is also a shortage, a dearth, so to speak, of folks with access to actual sickle cell disease specialty centers. And so once again, there are different models, there are different approaches, but many people with sickle cell disease are not managed by a sickle cell disease specialist. And so therein also lies a big problem. So it's kind of a workforce, I don't know if it's a workforce shortage on the side of hematology. I do know that the American Society of Hematology is trying very hard to increase the numbers of trainees who are going into non-malignant hematology with a focus to drive them or focus to encourage them to consider sickle cell disease as a sort of viable career track, and I'm happy to be a part of that. And obviously, I feel very strongly about that. But there is we also have a shortage of workforce, and so it is our patients have access in both hematology as well as access issues in both hematology and palliative care for sure.
And then, as we mentioned, there's clearly policy implications for almost anything related to sickle cell disease, partly because it's so underfunded and partly because so many people with sickle cell disease are insured by public insurance. Therefore, you need public insurance to get behind any changes. Therefore, Medicaid and other insurers have to make end-of-life and palliative care needs in sickle cell disease a priority to make sure that if a patient would benefit from palliative care, that they can have that referral approved and get reimbursed for seeing those people. And also in general, that goes with everything, making sure that there is sufficient reimbursement for palliative care and advanced care planning in people with sickle cell disease and others, because it's an area that takes a lot of time, but does not always get reimbursed well. And then training the palliative care workforce to take on more chronic disease patients, because as we talked about with that shortage, a lot of the chronic disease patients take up a lot of time. And so making sure that they have the training and bandwidth to help manage patients with chronic disease. Recently, the Palliative Care and Hospice Education and Training Act was passed that increased funding for both specialized palliative care and primary palliative care training in this country to increase the workforce. And then, as always, really needing more money for sickle cell disease research to help address these types of questions, in addition to the standard questions of how do we improve survival overall in people with sickle cell disease, but also to support them through the challenges that they have. And just a lot of thank yous to go around, and really the sickle cell data collection program was the driving force behind this. They had all this wonderful data and were interested in looking at these patterns so we could better figure out how to serve people with sickle cell disease as their death approach. So really huge thanks to Susan and the rest of her team for that. And then the institutions we have worked at during this, and I've been at Stanford and University of Alabama at Birmingham during this course of this ongoing project.
Yeah, no, it's definitely a team effort or a family effort. I'm at the University of Washington, but I will be transitioning to UC Davis Medical Center, and I work closely with sickle cell researchers, and one of my long-term mentors is based at St. Jude Children's Research Hospital. So these have all, and I trained with Dr. Johnston at Stanford, so we go way back. But these are different institutions. We owe them a lot of thanks for supporting our work. And next slide, please. I especially want to extend my thanks to the audience and to my patients that I take care of. I love this photo. I love that it's a little child who is very proud that he's a sickle cell star. And I also like the fact that you can see everybody behind, supporting them on what looks like a sickle cell disease walk, like many that we've attended. It does take a village, and it takes many of us putting our heads together and inviting many people to the table to make a dent in this disease. And I'm very proud to be a part of it, and very thankful every day for the patients that I take care of. So thank you. Thank you once again, Emily. Thank you, Susan. Thank you, Nani. Thank you, everybody, for this opportunity to share our work.
Wonderful. Thank you both so much. And at this time, I'll turn it over to Susan for our question and answer portion.
Thank you. Really, just a remarkable talk. I worked closely with you both on this paper, and I still learned an awful lot listening to your presentation today. So, and I have more questions myself than usual. And we have a number of questions already coming in. And so I want to remind folks, if you have questions of the presenters, please type them into the question box that you can see in your little control panel. So I want to take advantage of having the microphone for a second and just really call out the bullet point, and you did talk about it, but call out the bullet point that to me so resonated with the work that we did on the paper, which is that every acute event, every emergency department event, every hospitalization is really a life-threatening moment for someone with sickle cell disease, and that predicting someone's likelihood of death is really hard, given the data that we're looking at, and so these encounters need to be treated in that way, and I don't think they always are. And so I just wanted to, I know you said that, but I just really wanted to underline that point as well, coming out of those data. So Bimpe, you're starting to investigate the possibility of including a palliative care model in what you're doing in Seattle, and also, parenthetically, I'm so excited that you can now officially, that we're hearing that you're officially coming to California, because I think that's just an enormous asset for everyone living with sickle cell and working in the field in California. I'm thrilled to hear that.
Thank you.
So what is the response from patients as you start to talk to them about this model? We talked about putting out some materials about supporting a palliative care model for sickle cell disease, and we got a lot of pushback from primarily from healthcare providers. So I'm curious as to how those conversations are going for you, and what people think.
Yeah, thank you. That's a really important question. To be honest, I would say that I was probably on the side of not being initially open to a partnership with palliative care, and it took our social worker, who's dedicated to our program, our sickle cell disease social worker, who I hope is on the call, Angela. She's been fantastic and a great asset to our team. But like I said, she is sort of in both worlds, right? So she's in the supportive care department as well as in the sickle cell group, and so it took her opening my eyes to understand that there is a lot more to sickle cell disease than more to palliative care actually than end-of-life management alone, which is what I had had the very, very basics of understanding on what palliative care involved. And so when she explained to me, as Emily did in this talk, that there is a very broad scope for palliative care, I was immediately curious, and I sort of let go of my prior reservations. And then when the palliative care program director reached out to me at my center, reached out to me to extend, basically a friendly hand, like how can we work together to better serve your population? I sort of took that and jumped with it. And so once again, a lot of the things that I shared in this talk regarding that partnership is still in the very early infancy or in the sort of hypothetical phase. We haven't actually implemented it, but we had really good discussions in person and then also via email about how we can make this work. With regards to how patients have received it, so we've had one patient, or actually two probably, that we thought about sending or referring to our palliative care colleagues. And once again, the burden, it does fall because we are an embedded center. They have to physically go somewhere else to be seen by palliative care. I would say probably one of the potential upsides of this epidemic, if you can think about it as a potential upside, is that telehealth is now more readily available at our center. And so that's sort of decreased that burden on my patients of sending them to yet another subspecialist to get care. So what I'm hopeful for is potentially joint telehealth visits with palliative care and me or any member of my team who provides direct patient care to our patients, and then having that approach that I had seen modeled so excellently in the pediatric side in pediatric comprehensive sickle cell centers, and just have that a semblance of that for our patients. And so once again, for me, it's mostly stemmed around pain management or chronic SCD pain management, and a failure of managing these patients with opioids solely, and trying to figure out a more comprehensive approach to sickle cell disease overall, and then with a focus on with a goal of managing chronic pain. So patients are definitely open to that because chronic pain or pain in general is front and center for many of my adults or a few of my adults, but it's a big problem, and it's something that, I feel like my hematologic skills are not as capable or adept in managing as those of my palliative care colleagues. So therein, we definitely have buy-in from patients to explore this opportunity. And what we're just working on is decreasing that barrier of putting that burden on patients to go to another provider and trying to bring that care, that specialized care, to them in the comfort of their homes. So yeah, those would be my points. Yeah.
So you can't see it, but as we talked about, we didn't do the video, but I'm nodding emphatically because the next question I was going to ask was about how often I'm hearing in meetings with clinicians right now about how well telemedicine is going for people with sickle cell disease in the advent of shifting everything to telemedicine. That I've heard over and over again from clinicians that some of their patients are doing markedly better in terms of acute symptoms, in terms of emergency department utilization. And so I wondered how that all fit together. So you've addressed that a little bit, but do you see this sort of all merging together over the long haul? That the sort of more frequent encounters with patients is a part of palliative care, and that this new model of telemedicine can support that?
I definitely see it being a way in the future. So one of the things that I'm excited about is, going forward, we kind of give patients the option. Do you want this to be a telehealth visit, or do you want to come in person? And I'm seeing more and more people opt for a telehealth visit because it's just more convenient for them. One of the models of managing chronic sickle cell disease pain is to have, especially if there's any issues with opioid tolerance or opioid accountability issues, one of the ways to manage it is more frequent visits. And sometimes we ask patients, it's an incredible burden. Sometimes we ask patients to come once a week, once every other week. And in addition to their sickle cell, there are many other things that they're dealing with. And so I recognize that telehealth is a way to circumvent this huge burden that we place on patients with sickle cell disease. And so I'm very optimistic that it's something that we can continue well into the future. Whenever this pandemic ends, I think it's here to stay. Telehealth is here to stay. And yes, it has definitely been a big boost as far as decrease in our quote unquote no-show rates because folks are in their home and we can just remotely chat with them. It's been incredibly helpful, I think, for my patients. But we'd probably have to do a deeper dive to see if that is translating to decreased emergency room visits, because right now folks don't want to go to the emergency room, given their concerns about potential exposures to the coronavirus. So I'm not really sure. It might be a bit of an artificial decrease in emergency room utilization for some folks because of the current situation. But, hopefully, if and when this pandemic is over, this useful resource of telehealth will continue, and then we can more accurately measure if that translates to decrease acute care utilization.
The other thing that I wonder about a lot, which again, I have a lot of questions about how to integrate palliative care better into care of people with sickle cell disease. But one of the big advantages of a lot of palliative care doctors is that that the certification is for both pediatrics and adults. So a lot of people work at both, a lot of palliative care physicians work at both pediatric and adult centers. And with all of those issues with the pediatric to adolescent and young adult transition, I also wonder a lot about what role palliative care can play in terms of being some continuity between pediatric and adult centers, and whether or not that would also help with the access issue and decreasing no-show rates and things like that in that really vulnerable adolescent and young adult age group.
Yeah.
That's a really good thought. Yeah.
Let me ask you a couple of the really great questions coming from the audience as well. One of the ones that I think would be helpful for me as well is a question. Can you please provide an example of palliative care day to day for a patient with sickle cell disease? And I know you talked about there really being sort of 3 different levels of palliative care. And so I'm sure it would look different for each of those levels, but maybe just briefly talk about, another question was about where does pain control end and palliative care start? And I think the questions are sort of related. How would this really play out in the life of a clinic patient?
Okay, I'll take a stab at that. So I can give a real world example, which is still, like I said, a work in progress, but something that I envision. So, my clinical panel is mostly adults with sickle cell disease. And so I would be considered somebody who does offer primary or basic palliative care, because I am on a per each visit, we're going through chronic complications of sickle cell disease and disease modifying therapy. And so we're addressing a lot of those issues. Very similar to oncology or cancer patients, oftentimes the oncologist becomes the primary care provider, which is not ideal, but we are all trained in primary care as well. So oftentimes our patients aren't able to, I always encourage them to have a primary care provider, because I don't, the further out I am from training in internal medicine, the less adept I am to up-to-date measures or up-to-date primary care. But oftentimes we take over that aspect of our patients. And so in a way, I am providing chronic disease management in the context of a sort of basic palliative care model. And, I fall into that category at the very bottom of that pyramid that Emily showed earlier in the talk. To give a specific example, I can think about a patient that I have right now with severe sickle cell disease, severe chronic pain, and multiple comorbidities. And I believe this patient would be best served as a co-managed patient with palliative care, because I can deal very, very well. I'm very adept at managing their disease, their sickle cell disease, but I haven't had a lot of progress or a lot of inroads in managing all the other complications. And so if I focus on sort of the chronic sickle cell disease pain aspect of things, my hematology training is inadequate in managing the chronic sickle cell disease pain with non-opioid therapy. So non-opioid or non-medication approaches. And so when I think about it, I would say, okay, chronic sickle cell disease is multifaceted, it's multimodal, and I can address a certain aspect of it with NSAIDs or opioids or potentially SSRIs or whatnot, but it's very limited in scope. That's what I know, and that's what I know to do. But then if I need to refer the patient to chronic pain, or I need to refer them to psychiatry or psychology, or refer them to physical therapy or integrative medicine, there's so many facets of chronic pain management that I don't have expertise in, whereas somebody with palliative care medicine training would know, what to start or what to initiate and in what order. So in that example of my 48-year-old man with severe sickle cell disease, I envision a partnership with palliative care to better manage himself as an overall person, not just the small facet of sickle cell that I have expertise in. I hope that's a sort of concrete example of how I envision partnering with palliative medicine for a real life patient that I admit that I am struggling with managing their whole disease, actually. But I think having palliative care co-manage this patient would definitely be an asset and definitely improve his quality of life.
Yeah, I think that's really helpful. I'm sorry, go ahead, Emily.
Well, I think the other thing that we need to better understand too, as you mentioned, is who with sickle cell disease will most benefit. I don't consult gastroenterology on every patient who has an elevated bilirubin, and I don't need palliative care for every patient who's dying or has pain issues, but really figuring out we need to better understand who are the people who would most benefit, so we can then be a little bit more targeted. and then figure out these models of how best to integrate. I think it's hard.
I agree.
Yeah, I agree. I'm just flipping through. Yes, lots of good points being made here. One of the questions that came, I have two questions that came up around the study itself. And one was just a clarification on who the controls were. And so I'm wondering if you might touch on that, Emily.
Yeah, and so the controls were live people with sickle cell disease, and we age matched them with the deceased cases at date of death. So if somebody was 21 when they died, we matched them based on gender, race, ethnicity, although that was pretty much universal, and insurance based on date of death of that index case.
Yes, that is my memory as well. And then another question that was relevant just to the study itself was about Medicare data and whether that was included. And I can answer that one. And the point that's being made is many in other states are not eligible for Medicaid and only have Medicare. And this is true. Medicare data was not included in this study, or I guess the way to put it. So our focus was on acute care utilization. So I'm gonna back up what I just said. So we are able to see both Medicare paid hospitalizations and emergency department visits, as well as Medicaid in the data that we used. And so Medicare data were included on that, in that sense. We are not yet able to see people who only have Medicare claims in our cohort. So there may be some people who were not included in our cohort who do have sickle cell disease. If they had a substantial amount of acute utilization, we would have included them, even though we can't see their Medicare claims. So it's a little bit convoluted, but I think that comparing Medicaid expansion states with non-Medicaid expansion states is always a little bit tricky. But our experience doing this with California and Georgia is a non-Medicaid expansion state, have shown that for most of what we look at, actually the results are fairly similar with our data. So I did just want to address that briefly. Lots of questions about different models, and I don't want to get too far off the track of what the topic of the conversation is, but one is about, and I'm going to rephrase the question, why the hemophilia treatment center model is not used in sickle cell disease. And I certainly have opinions on that, but I'm not the speaker. So I'm going to ask if you guys want to respond.
I can try to take that one. So I didn't include that as one of the examples of sickle cell disease models because it isn't mainstream. The hemophilia treatment centers, there has been, as Susan says, there are many thoughts about why that is not the case, but I do think that might change over time. So as many of us know in this audience, for decades, all we had to treat sickle cell disease was hydroxyurea. Hydroxyurea has been around forever. It was FDA approved in 1998. It is pretty cheap, very affordable, and it does a very good job. I'm a huge fan of the drug. And it took another 20 years or so before L-glutamine was FDA approved for sickle cell disease. And even in real time, it's often very difficult to prescribe L-glutamine. So just to say that we didn't have expensive drugs to treat this disease, and so it was very difficult to incorporate that into the 340B program and sort of marry in or incorporate sickle cell disease under the HTC model. But I suspected that might change with the advent of newer therapies, newer, very expensive therapies for sickle cell disease, so crizanlizumab infusions or voxelotor. That said, I don't know, to be honest, I don't know what the whether or not the 340B program for hemophilia treatment centers will continue in its current format, but it is definitely a potential model for the management of sickle cell disease. I mean, once again, it's a rare disease. It affects a small population, mostly an underrepresented population of patients. And so access to something like the hemophilia treatment center is a long-standing issue that has many explanations for why it hasn't been the case for folks with sickle cell disease. That is tied into either racial injustice or bias. And not to get off topic, I do think that with the new medications on the horizon, or the new medications and many more on the horizon, I hope for the management of sickle cell disease, that this model can be explored in the future to the benefit of our patients, because getting the financial support from a 340B program for folks with sickle cell disease would be a huge game changer. Many of the resources that our publicly insured patients do not have access to would then be available to them. And absolutely, I don't see how that would not make a significant improvement in mortality and overall quality of life for our patients. It is indeed something that all of us in this field really hope for and are working very hard towards. Yeah.
That was beautifully expressed. Thank you. Do you mind sticking around for one more question?
Absolutely.
We've gone a little past the hour. So the question is, how has your use of telemedicine affected your ability to monitor hydroxy use, labs, and other quality indicators? So touching back on telemedicine again, relevant again, because I think it does support the idea of palliative care at all levels. But what does that mean for the future in terms of these kinds of things?
That's a really excellent question. So I have become a sleuth. I'm very good at looking at the electronic records and figuring out when my patients are going for X, Y, and Z visits. Here at the University of Washington, we have many University of Washington neighborhood clinics spread within Seattle and the greater Seattle area. So I can easily figure out, my patient lives in, let's say they live in Tacoma, or they live, whatever, they live, away from Seattle Center. What is the closest neighborhood clinic that is close to where they live, and can they go there for a blood draw? And we try to time it in such a way that the labs become available. I can put in the orders into the electronic record, into their electronic medical record, and that order gets faxed to the neighborhood clinic. And then they get their labs drawn in the neighborhood clinic, and the result comes back to me. And then it's ready and open to me at the time when I go into the telehealth visit. It's extremely satisfying to be able to pull up, I can see my patient, I can see them, they can see my screen, I can share the screen with them and show them, oh, these are what your lab showed, let's modify the hydroxyurea dose, or let's change X, Y, and Z. And we can go over it in real time. It's almost like it's the same as we would do in person, but they've already had the labs done before. I feel like it's more efficient, and honestly, it's more convenient for the patient. It's such a big weight off their shoulders, where they don't have to drive into the city, park, or struggle for parking and invariably be late or miss their appointments. And so for us, at least at our center, it's been very well received. And yeah, we've had to finagle a little bit and try to figure out, how do we get the labs in time or whatnot. For the most part, it's worked really, really well.
Thank you very much. I'm going to, you guys have been at top level performance for over an hour now. And so I'm going to stop asking questions. I think we're getting into questions that are more about the problems with our healthcare system, which are enormous and probably need another webinar. But I just really want to thank you so much. This has been so helpful, and I think opens up a conversation that really needs to be opened up to talk about expanding our models of care, how to fund those, and where we might be able to go. So this is a great step forward. Thank you.
Thank you.
Thank you so much for having us.
Yeah, thank you.
Yes,
We
thank
appreciate
you
it.
all
Thank
so
you.
much. This concludes the time that we have for this session. I just want to thank everyone who participated. We really appreciate you being here and joining us today, and we'll see you next time.